Welcome to MAP, the bi-weekly market access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. Mars makes it as easy as possible for you to get your pharmaceutical, medtech, or digital health product to the market and, of course, get the price it deserves. My name is Stefan Walzer. I'm the founder of Mars and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics already since 2004. Additionally, I founded the consultancy P&N Pricing and Negotiations in Healthcare based in Toronto, Canada, which supports companies and individuals globally by coaching, simulations, and training, especially on negotiations. This service is including our innovative virtual reality simulation program and is part of the Negotiation Lab. And now let's learn about the market access and reimbursement systems around the globe. Good morning, Nina. Good morning to Toronto, I think, right?
Yes, absolutely. It's 9:30 in the morning here in Toronto. Thank you for having me on your show, Stefan.
Perfect. Good to have you. And I think a very interesting kind of topic this time. I think normally we discuss more around, let's say, market access reimbursement systems, the discussions around payers, etc. But I think today it's even a bit broader. It touches very much on all of those kind of aspects, but it's clearly broader. It's around pharmacoequity. So, Nina, before we start with that, maybe you can introduce yourself as well before we then jump into the topic, that we don't forget that.
Absolutely. So I'm Nina Lathia. I'm a pharmacist and health economist. I worked for several years as a hospital pharmacist and then sort of rejigged my career by going to graduate school, obtaining a master's and a PhD in health economics. And in my career as a health economist, I've worked both in Canada and internationally at NICE, the National Institute for Health and Care Excellence in the UK. And as a consultant, I've done work for government agencies, I've done work for private payers, and I've done work for some pharma companies.
So that's perfect. Perfect guest for our show.
Thank you so much for having me. It's such a pleasure to be on.
Absolutely. So coming back and going back, I mean, I think it's probably also quite interesting because I think you have chosen pharmacoequity also as part of a quite recent paper, and you can maybe just as well speak to that very quickly. But I think when having your kind of background with UK NICE, with the Canadian healthcare system from private side, but let's say from the different perspective, I think you have probably also chosen that topic quite nicely. But before we come to that, could you quickly tell us what you define or how you would maybe define pharmacoequity? What is it finally?
Yeah, so pharmacoequity was a term coined by a U.S. researcher who's written a very nice paper that you referred to in JAMA 2 years ago. And this term really refers to ensuring that all individuals or all groups within a population have access to high quality medications that improve their health outcomes, regardless of characteristics such as race, ethnicity, socioeconomic status, or any other individual factors. And, we know from existing data that there are disparities in access to medications. And I think the goal now really should be is how we achieve pharmacoequity on a population level.
Exactly. I think that's very important because I think when I first heard that terminology, I was more thinking about, let's say, those kind of differences between, let's say, regions. For example, that a product might be available in Scotland, but maybe not in England, right? So just by chance, or the same in Canada, right? Maybe it might be available in one province, but not in the other. That was the first thing what basically rang a bell with me. But I think it's even broader, right? You just said it might be a lot of discussion we just have probably since a couple of years, right? Which is age, gender, social kind of, generally let's say the kind of social environment, right? Where you're coming from, etc. So how could we tackle that really? Because I mean, ultimately it is really broad and it's nice, let's say from an academic perspective, but ultimately it really touches space with every patient, right?
Absolutely. And I think what you touched on is absolutely one important component of pharmacoequity, differences between regions within a country or globally with respect to access to effective medications. But really, when we kind of take a step back and we look at it, these inequities are sort of embedded in the system all the way from drug development right up to an individual patient obtaining a prescription from a pharmacy. And I think in order to tackle this, we need to look at sort of every point along this continuum, and strategies for addressing these inequities at every point. So, for example, when we look at drug development, we want to ensure that, in the drug pipeline, we are developing remedies for the vast array of diseases that individuals experience around the world, right? We don't just want to be developing specialty medications, targeted at individuals living in what might be considered rich countries or high income countries. We also want to make sure that we are developing drugs for neglected tropical diseases that affect huge swaths of the population in the global south, right? And moving on from there, we want to make sure that we make appropriate regulatory decisions and we integrate equity considerations into regulatory frameworks, right? And I think up until this point, there hasn't been an appreciation as to how to systematically consider equity all along that continuum. And, moving on from the regulatory sphere into HTA bodies and how they make decisions, individual prescribing decisions, and access by individual patients to these drugs, I think is important. And I think there are steps we can take at every point along that continuum.
No, I fully agree. And I think the other thing would maybe reminds me of, I think it's maybe a very special case, but it could maybe as well be something what could maybe as well be implemented in the different systems. I think when we think about orphan drugs, I mean, maybe 10, 15 years ago, there were no real incentives, also not for the pharmaceutical industry, right, to really invest there, even with very small patient population, right? If we see now those ATMPs with, 9 or 10 patients maybe per country, I mean, no one can really say anymore that this is not attractive, right? Prices might be really high, right? But that's maybe on another aspect. I think we're probably even a step before that. And I think you said that, but an orphan drug is just more what maybe was an idea how to potentially create some incentives, or especially also on the regulatory side, right? When we speak about drug development, and you would think of, let's say, trying to decrease, let's say, pharmaco inequality, right? What would be, let's say, incentives or maybe steps you would think would make sense to also at least have that first step, right? From clinical trial into regulatory approval. How could we, let's say, make that a bit more, maybe call it fair?
Yeah, so I mean, I think governments play a huge role in that, in providing incentives in terms of funding development, in terms of regulatory decisions. I think there are definitely government incentives. I think maybe we need to look at the issue from a global perspective too, ensuring that we, globally. I mean, there's the issue of orphan drugs. There's the issue of diseases that may be more prevalent in the global south rather than in high income countries. I definitely think there are financial incentives to be had or to be taken when we try and create these incentives. Absolutely. And I think then again, when we kind of move to the regulatory steps, I think we're making some progress. We see with diversity as well in these trials. I think that's another component with respect to equity, right? Traditionally, there hasn't been a great deal of diversity in clinical trials. And I think that point has been underappreciated because many of the drugs that are developed are potentially useful in patient populations in which we haven't evaluated in clinical trials, right? So, and I think there's a greater appreciation of that. The FDA has now recommended or has now implemented diversity requirements for late-stage clinical trials. So I think we are starting to realize that we do need to do this. And beyond the regulatory framework, when we get into HTA decision-making, I mean, traditionally HTA was focused on population health and maximizing population health, right? And there wasn't really a formal equity framework, but I think HTA bodies are now realizing it's not just about improving the health of the whole population. It's also about how that health is distributed between different groups within the population. And we know that there are, even in rich countries, there are health disparities based on socioeconomic status, as we discussed before, based on race, based on ethnicity. And so HTA bodies are looking at formally incorporating equity considerations into their decisions through use of things like distributional cost effectiveness analyses, which formally quantify equity and how those equity outcomes are distributed between different groups in populations. And again, I think that comes back to your point about orphan drugs, right? That we have that group of patients who up until very recently haven't had specific therapies that were being developed for their conditions, right?
Yeah, exactly. I mean, orphan drugs is just one example, right? I mean, if we take, for example, pediatrics, right? I mean, if you have suddenly a pediatrics program, you also get a longer kind of, let's say, time until your patent might expire from an industry perspective, which is also a quite interesting incentive. So you might even think of, let's say, broaden that. Instead of just saying only pediatrics, you could even say it's more kind of diversity factor, right? So have you, let's say, done everything to really, let's say, implement a kind of, I don't know how to say it, but it's probably more that the different kind of inequality measures have been at least being considered, right? It's difficult, right? Because as you said, it's
Absolutely.
different factors, right? Age is one thing, which is maybe a bit more easy to implement. Race maybe as well, even though that, then it again depends where you have run your study, right? We know from Asia, for example, that they require a given percentage or proportion of patients in the trials needed to be basically Asian based, right? Then if you don't have that, you need to have another follow-up study. So that could also be maybe some of the ideas, because if you don't do it, you maybe get the kind of request to run another study on those kind of diverse patient groups, which also costs a bit of money. So that could also be maybe an incentive, maybe easy to implement, I'm not sure, for the industry.
Absolutely. I think that, depending, I suspect, on the specific drug and the specific trial, it may be easy to implement. It may be a little bit more difficult to implement. But I definitely think mandates and incentives of those kind are important in ensuring equity of access, right? And, I think an important part of pharmacoequity is ensuring access to drugs that improve health benefits, right? And so we want to see evidence of improvement in health benefits in those particular groups, right? So I think that I think that is very important, and I think these mandates are an important step in ensuring that we have, fair representation of all individuals who may be candidates for a particular drug therapy, right?
Yeah, no, I fully agree. Maybe a kind of more critical question. I mean, I've quickly spoken the last couple of days with a few payers from Europe, and we're also speaking about the podcast generally, right? And I was telling you, look, I mean, I'm looking forward to a quite different discussion we now have, right, on pharmacoequity. And then, obviously the question came back, but what is it really? And we had a quick discussion, and I think two of them basically said, but is that not generally more the generalizability of RCTs into real life, so into the real world? What do you think about this? Is it really only generalizability, or is it even more?
I think generalizability is a huge component of it, right? Because I think it's just harkening back to our discussion about, can we apply results from a certain patient group to real world clinical populations, right? And I think the answer up until now has generally been no, because there hasn't been a great deal of diversity in terms of inclusion criteria of clinical trials. So that's certainly an important component to it. But I think it goes well beyond that, because even beyond a clinical trial, we have equity of access, and not just access to medications, but access to prescribers, who prescribe these medications, right? And we know that there is referral bias. We know that racialized individuals, are less likely to be referred to specialists who prescribe novel therapies. And just on that point, we know that generally pharmacoequity, these inequities that we observe aren't just related to access to high cost novel therapies. They're across the board, even access to low cost generic therapies. There are disparities between groups within a population. So there's the issue of access to prescribers. And I think on that note, we also need to discuss issues around, culturally safe healthcare. Do certain groups have a legitimate mistrust of the healthcare system? And as a result of that, they're not accessing the system, and they're not receiving access to these therapies, right? And what can we do about that? And so, just an example of addressing that was a study done quite a number of years ago now, I think, and written up in the New England Journal of Medicine on treating hypertension in Black men who disproportionately experience that condition through a collaboration between pharmacists and barbershops in Los Angeles. So, I mean, that was another, where they were more likely to take medication to address their hypertension, and they achieved excellent health outcomes with blood pressure reduction as a result of that program. So I think there's that issue about, access and uptake. And then there's the issue, particularly in countries like the US, where there's private insurance, right? And in many cases, we have patients who could be uninsured or underinsured, in that their insurance plan expects them to bear a high out-of-pocket cost for medications. And as a result of that, they choose to forego care sometimes. And I think that's another issue, ensuring that, we have population-wide access to fair, low-cost insurance programs that don't incentivize, so to speak, foregoing healthcare, right? That's one issue. And I think HTA bodies in countries that have them, I think also play an important role there in terms of price negotiation, right? Ensuring that fair prices, we're paying fair prices for medications, right? And that comes back to another broader issue, which I think is overall sustainability of the healthcare system, making sure that these drug budgets are sustainable and we can continue to pay fair prices for drugs that improve the health of individuals within a particular population.
Yeah, no, fully agree. And I think you mentioned a lot of really important things. I think maybe we even very quickly touch base again on the inequality, and I think quite recent examples how it could work, right? Meaning access to drugs or access, let's say, to care in general, right? I mean, if we maybe look back to the COVID-19 vaccination program in Canada, right? It was basically made that the care basically came to the people, right? Wherever those people were, in terms of language, social status, generally where they were living, etc., right? It was all thought, how could we bring the vaccination to the persons, right? Which is totally different, I would say, to at least most of the times. This is probably, again, not only in Canada, but I think across the world, where everybody's more thinking, okay, we have a drug, we have a physician, the patient will come or not, right? Which is a bit different. I like your idea very much from the US, with the hypertension, but that's exactly one of the points. But the question is, how could we really, let's say, get that implemented? Because ultimately, you also touch base on sustainability, right? If I would think about managing a budget, a healthcare budget, right? I would also not only need to think what I spent now, but I would at least need to think about, firstly, about the outcomes of patients, right? And secondly, how to even improve outcome, which might even, let's say, reduce costs overall in the long term, or maybe in midterm even, right? And that was maybe also something what you have just said with your hypertension example, right? If hypertension is controlled, you ultimately have, for sure, significantly less kind of a budget impact in a way for whatever kind of complications it might arise from that, right?
Oh, absolutely. Absolutely. I think we need to take a long-term view, through the lens of pharmacoequity, like what, it's not just about the cost of the drug, right? It's about the long-term consequences of ensuring people have access to therapies, right? Preventive therapies, novel therapies, low-cost generic therapies, whatever therapies they require to manage their conditions. And I really like your mention of the vaccination program in Canada. I think we had a lot of success with groups, particularly with Indigenous groups, kind of going to them and designing programs that were aimed at increasing uptake and increasing trust within the system. And I think that was one of the very bright spots for Canada, at least in terms of vaccine uptake. And it wasn't. I mean, I think the most well-known example is within Indigenous communities, but there were also, religious groups that partnered with the government to administer vaccines, in temples or mosques, et cetera. And that was absolutely a very successful program. And I think that really speaks to, the core of really what pharmacoequity is, right? Like ensuring people who need these therapies get them. And it doesn't have to necessarily be in what would be considered a traditional healthcare setting, like a doctor's office or a hospital, or even a pharmacy.
Yeah, no, I fully agree. So I think ultimately, I think what this really shows is that there needs to be probably somehow a kind of political push, right? Or a kind of monetary incentive, probably both of it, right? Because I guess for, let's say with the example in the US, I think it was probably also a bit of a monetary incentive, right? I mean, if we can get those, let's say, patients being controlled, we might see in the long term less costs, right? Which maybe, I don't know what that was the kind of incentive or the kind of background, but I could at least think about that, right? I think the political push is probably more what we've seen with the COVID vaccination programs, right? In Canada, but also in other parts of the world. The other issue, I think, what maybe needs to be added in here, I mean, what you said as well, is access to physicians in general, right? Because, I mean, we have quite high scarcity, obviously, already with nurses, with physicians, with pharmacists, whatever you want to call it, right? So how could we solve that really in the future? I mean, overall, right? How could, let's say, inequality to pharmacotherapies or maybe to even broader to, let's say, care access be solved in midterm to long-term run? What might be next step, what you would and could think of?
Yeah, so that's a really good question. And I think that's a particularly salient question that's come to light with the COVID-19 pandemic, right? We've seen an increasing number of shortages of nurses, doctors, other frontline healthcare workers. And it's not an easy problem to fix. But one bright spot that I will mention, and perhaps this is my bias as a pharmacist, has been, the expanded scope of pharmacy practice, at least within Canada. We've seen, I think, all of the provinces, all 10 provinces and the territories in Canada move towards expanding the scopes, allowing pharmacists to prescribe certain medications for ambulatory conditions. Mm-hmm. In some cases, allowing pharmacists to become more involved in monitoring and following up of therapies through authorization for ordering lab values, making some therapeutic substitutions, really sort of making pharmacists key players in an access point to primary care. I think has been, one of the positives to come out of that. Mm-hmm. I think, recognizing, coming back to your point, that healthcare doesn't always have to be delivered in what is a traditional healthcare setting, right? In establishing even community-based organizations that can deliver healthcare, delivering healthcare to children in schools. There have been some studies to show that that's been an excellent program to increase uptake. For example, of HPV vaccines, we know that when they're administered in school, we have higher uptake than when parents are required to attend appointments in traditional healthcare settings. So I think that we maybe need to think a little bit outside the box, and we need to think of, the fact that healthcare is not, doesn't exist in a vacuum on its own, right? It's interconnected to other programs and to other initiatives within a community. And I think that that would be an excellent direction for us to move in. And I think we're getting there. And I think what's important too is that we engage patients in helping them to understand how they can access healthcare.
Yeah, no, I fully agree. I think it's really important. I think when you said, I think we need to think obviously outside the box. I think it's very important that, let's say, healthcare is not just, let's say, running in kind of fixed kind of boxes in a way, right? I mean, it is broad. It's basically affecting everybody every day, right? Whenever we wake up or whenever we sleep, I mean, everything is related to health at the end of the day, right? So we should probably even have that a bit broader. I mean, we had some discussions here, at least in some countries in Europe, for maybe call it practice on the go, right? So private practices, which might just jump, let's say, from one location to another, to also, and especially having maybe access more for elderly, no more, let's say, that flexible to go maybe into the bigger cities than to their appointments or something like that. I mean, we've seen that this would work. Seen basically with the vaccination program, but it's still not implemented, right? It's just a small step, but I don't know, maybe it's still the money which is missing, or maybe the political will.
I think it's probably both the money, the political will. I think there's still an underappreciation as to how important some of those programs are. And I think, on a societal level, we need to implement systems to deal with this, right? Like we need, that's an excellent idea of maybe, sort of pop-up clinics or mobile clinics, but we've got to have, I think, a system-wide approach so that everybody who could benefit from that has access to it, right? In the same way we talk about equity to medications, right? We've got to have systems in place to ensure that everybody has access to the healthcare, be it medications or other healthcare services that they need. And I think I think that's the key. I think we
agree.
also, I think you mentioned incentives. I think we also, in some cases, need to address what might be described as misaligned incentives, right? Where we might have some, perverse incentives that are causing us to behave in certain ways or not behave in certain ways that are affecting access, access to medications and other health services. So I think there's lots to think about there. Yeah.
No, absolutely agree. So final question for you. What would you tell if suddenly the Minister of Health, the Canadian Minister of Health, would call you tomorrow and would just ask for your advice? You have maybe 2 minutes time and somebody was just recommending to speak to Nina and you have 2 minutes to tell the Minister of Health what to do, what you would basically do if you were him or her.
So I would say, just on the issue of equity, I would say, put in system-wide processes, implement some system-wide processes to address health inequities and start early, start with children, start in school, start teaching children about health, start teaching children about where they can access health services, start teaching children about things they can do to stay healthy. And I would also say my second piece of advice is take a long-term view. I think sometimes we're all guilty of what could be described as short-termism. Take a long-term view. How does access to medications, how does access to health services benefit us 10, 20, 30 years down the line, not 6 months down the line, not what it's going to cost for the next 6 months, what it's going to cost for the next year. What are we going to achieve if we implement these programs, a decade or two down the line? And I think that's very, very important. That's key to making good decisions.
Yeah, that makes a lot of sense. Thank you, Nina. It was a great discussion, a lot of great insights and a lot of new, let's say, parts also to think of.
Yes, lots of food for thought. So thank you for having me.
Thank you. So pharmacoequity this time is slightly different kind of topic, but it's still very important when thinking about market access and reimbursement itself. I mean, people listening to the podcast might have already experienced in the past as well inequalities in access of drugs, for example, on a regional level. I mean, sometimes I personally had the experience that a drug we have been working on a national level, for example, in Spain, had access in some areas, for example, in the Barcelona area, but not in the south of Spain for nearly 3 years, right? So there was a 3-year difference until also patients in the south of Spain had the same access to that specific drug than patients more in the north. I think people who might know as well the system, for example, in Italy would just say, yes, of course, I've experienced that similarly. And I have also mentioned already in the podcast discussion with Nina, the experience between Scotland and England. So that's just one component, but it's even broader what we have just heard, right? It's also, let's say, something which might be coming as well into effect from an HGH perspective. We've just heard as well that there is a so-called distributional cost effectiveness analysis already, at least in the academic discussion, where people might just get as well the diversity into the cost effectiveness analysis. And I think we have that already, let's say, when we think and speak about the medical benefit assessment, for example, in France, in Germany, and in other parts of the world, when payers are speaking about generalizability. Generalizability of randomized controlled trials is also part, and an important part and component of inequality of drug access. So a lot of further discussion which might come in there, I think especially within the years to come. We're now in 2023. We have a lot of discussions from a political perspective when it comes to diversity, which I personally think is really important. And that is also where I personally believe as well that this will also get into the market access and reimbursement discussions rather sooner than later. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.